Thanks so much. I'm John Emerson. I'm the head of research and go-to-market at a company called Primary.Health. And we're a software diagnostics and really program management company in San Francisco. And we started during the pandemic, very much like this group did. And I myself am from Colorado, Denver, Colorado, where I helped set up COVID Check Colorado. So I really appreciate all the incredible work that this team and this state and this organization put together, and really appreciate the welcome that we got here throughout this process. Maureen Johnson-León is our head of research, and she focused on this air safety project that we did in an early childhood education program called Head Start. And so I'll go through our agenda today. So our focus is quickly to introduce who our company is, and then a little context on Oakland Head Start. And then we'll go through pilot details, preliminary results, some case studies, a discussion, and a conclusion. So a little bit about our company. There's a lot to be said, but to summarize it, much like many of the folks at SHIELD, we started as a volunteer response to the pandemic, and quickly realized that one of the things that we would be very good at would be developing a software platform. And the first thing that this was really used was research by other organizations. So we worked closely with UCSF in San Francisco, and with the University of Louisville in Kentucky, to support their studies on how we might scale various diagnostic programs. And as we got better and better at this, we became a really program management resource for the state of California, where we run all of the antigen testing at 4,000 schools, as well as with the state of Minnesota, where we help them set up their first mass vaccination programs, as well as doing work in schools and rural areas about immunization, updating immunization in schools, as well as a number of new projects we're working on. We are now the replacement for PrepMod in the state of Colorado. We have an STI home testing program we're working on, and we are also involved in viral surveillance. But the focus of this conversation today is air safety, which we really saw as a critical step towards infection control as the public health emergency was winding down. The central idea of our research program really is evidence-based research projects. We will always focus on vulnerable communities, and how can this research improve field implementation of programs. And we always make sure our research is leveraged so that we make our next program better. And with that, I'll let Maureen Johnson-León, introduce our Head Start program.
Hi everyone, it's so nice to see so many friendly faces that I've seen the past couple days, so call me Mo. And just a quick note for our tech team, the timer is not on, so we don't actually know how far in we are. Thank you. Thanks. So I've been in infectious disease research for a long time, did HIV and tuberculosis, and like most people and other public health practitioners, jumped into COVID. John hired me a few months ago to help lead the Head Start pilot program, which was really fun. I've done pilots before and love the kind of really up close and collaborative nature of them. I'll talk a little bit about Oakland and get the clicker. Is this the clicker?
That's it.
Sweet. Okay.
Green button.
So we're not from here. I actually live in Oakland. Oakland is a city just to the east of San Francisco. Many of you might be familiar with the Bay Area. Oakland Head Start centers, Head Start is the program that we worked with, are located in areas that have historically faced greater environmental racism, have faced redlining, and other policy measures that have damaged the health of the communities there, increased their vulnerability to disasters. If you look at these two maps, you see where the ports and the highways are on the map on your right. This is also where Head Start locations are located. The outdoor air quality is affected by these big things: ozone, PM 2.5, particulate matter, and other toxic releases happen more frequently in these areas. I actually live north in the yellow area, so I'm not as affected by these things. As you know, the COVID-19 pandemic was really, really hard on the more vulnerable communities. The same is true, of course, outdoor air pollution tends to happen to more vulnerable communities, as well as in 2020 all over the West, we faced these historic wildfires, which led to increased smoke. Studies have shown that the smoke from outdoor air pollution combined with the COVID-19 pandemic, particularly in these more vulnerable areas of Oakland, did lead to an increase of death and illness. For the researchers out there, I use an index often called the Social Vulnerability Index, which is a CDC metric that shows kind of a community's vulnerability to natural hazards. These are all highly vulnerable areas to these things. So both COVID, fires, and natural disasters. Head Start serves these vulnerable communities. They serve really essential functions for a lot of the families in the area. They have a mother and a baby program. They work with students that are 10 to 15% of their students are suffering from housing insecurity. So when they were shut down, it really was a problem for these communities. Every school was, and the goal is to keep them open and for longer and pandemic-proof. I'll talk a little bit about the air safety pilot details. A study from Italy that looked at the relationship between health impacts due to respiratory viruses and their effect on absences really informed the way that we looked at the study. Very different sizes of studies and very different kind of interventions that were available. So Italy's study was big, 1,400 schools, 10,000 classrooms, over 200,000 students, really looked from preschool through high school. And they were able to outfit over 300 classrooms with mechanical ventilation systems, so pumping in air from the outside specifically. Our Head Start program, smaller, more intimate, more targeted. It was great. 12 centers, 29 classrooms, about 200 students. These were the babies. It was under 5 children were in these classrooms. We already had existing kind of antigen testing programs, and we added an air pathogen monitoring component to it. It was also really focused on different types of generating educational interventions in addition to putting air purifiers specifically to combat indoor air quality in these rooms. We'll talk a little bit about some of the metrics for air safety, whether we're familiar with them or not. Many of you might be. Please feel free to ask questions. The most direct measurement that we used was this thing called an EACH score, effective air change rate. This measures the clearance specifically in the breathing zone. So you may have heard of ACH, the air change rate. This is measured when there's a vent in and a vent out on what the air exchange rate is. However, this one is more specific to rooms that may or may not have vents where you can measure that, and also specifically to the breathing zone where you are more likely to inhale somebody else's exhalation of a respiratory pathogen. We also did air pathogen monitoring, testing the presence of viruses like COVID and flu, and really there's a potential to expand to other viruses, which has research and practical implications, as we know. Some supplemental data, John will kind of go over some visuals in a minute, but coming into these classrooms, we did bioscans, which is this really cool way of seeing where some of the hot spots and dead zones are. In this room, you might imagine we feel the mechanical ventilation, but you don't know if you're sitting in an area with more airflow or less airflow. As you can imagine, in classrooms, children move around, so you don't know if they're going to be entering different types of air zones within the classroom, and so there might be limited scalability for these in classrooms because you can't give as many specific recommendations. And of course, too, we had rapid antigen testing, which everybody's familiar with. Our teachers and classrooms really relied and understood this intervention. Additionally, I think historically this was combined with some care systems. So you got tested, you could have access to care. So this was an intervention and mitigation measure they were very familiar with and could make decisions on quickly. John.
Thanks, Mo. So I don't want to get too deep into the technology. However, suffice to say, we had a 3-phase program for measuring effective air change rate. And that is the same metric, by the way, that was used for the Italy study, which really is sort of the gold standard now in understanding air safety in schools. So we are using a proprietary technology And the three phases are, first we get the floor plans and look roughly at where we're going to be measuring. We create a plan up front and understand which rooms are heavily used a little bit more. And then we set up over to the right of that image, that's the right, yeah, that sort of tripod set of a diffuser which sprays out a very specific air-tagged water molecule, and sensors which pick it up. So we set that out, we run that. It really takes only about 15 minutes to measure the diffusion pattern across a room. And then we leverage a data. Sometimes we're doing it via Wi-Fi, but what we do is get a score. And those scores are the baseline of how we're assessing how well the room is clearing out pathogens. And it can be infectious pathogens as well as smoke, pollen, a range of things. It measures portable filtration, portable purifiers as well, which is very important. Next slide, please. Oh, that's me. So we have a bioscan that we did for these studies. It's really a richer visualization of what's going on in the room. And as you can see, those red arrows, those are areas where pathogens tend to accumulate. And it is a useful tool because you could say, potentially rearrange a room, or potentially maybe you should put a filter where those red arrows go. But again, that's a lot of detail to do. We can't necessarily do a scalable program with it, but it's a neat tool. The other neat tool we have is a pathogen center, which can sense COVID, influenza, RSV. Really, there are a range of other things that we can pick up, leveraging a similar PCR assay on it, but it requires being sent to a lab. I want to stop briefly just to remind the big picture of why are we doing this, and it's quite simple. If you look at that slide on the left, you understand that if we don't have windows open or purifiers or doors open or an HVAC system, particles accumulate. And this is bad for teachers, it's bad for students. What we want is that view on the right. And you can see with the purifier is working, the window is open, there's less of an accumulation. Even the floor, by the way, has fewer pathogens because of the clearance rate. And so this is our vision of what we're trying to do, and this is a sample educational material we realized we had to do so that everyone bought into the program. Our quick timeline, really we started looking at this technology about a year ago. We did a pilot in the spring of last year. We did a press release on that, and that led us to Head Start Oakland reaching out to us to say, we want to do more. And that led to December. We did our assessment using these portable sort of tripods to do our measurements. We also, in January, decided let's try an embedded EACH measurement tool. And so we set up that, and then by mid-January through present, we've been collecting EACH scores, pathogen scores, and really collecting the data and thinking through it. At the same time, we hired Mo to get going on, really thinking about the data more systematically and making sure that we have something that we can publish. Lastly, we are finishing up around April 1st, which is tomorrow. No April Fool on that, we are. So we are just at the end of our process right now, so it's very exciting, and Mo can talk more about early results.
Awesome. So a couple of things. As John mentioned, the research design really followed the operational objectives. I think everybody here at SHIELD can understand that. We want to make sure that we get the tools and services as quickly to the communities that need them and ask for them. And then, in parallel or following up with that, do research. So the research doesn't impede what's actually happening. For this study, walking in and looking at kind of the previous pilot, what we expected was really that we could measure the EACH scores, the effective air exchange scores, following some type of educational intervention and see how they changed, and following the procurement of these new air purifiers that Head Start Oakland was encouraged to buy based on the initial bioscans. We also expected that we would be able to monitor the effective air exchange rate over time and see the relationship to absentee rates week on week or any type of other qualitative or quantitative variables that we might collect. I'll take a moment and pause and say that the first pilot that we did and the first measurement that we did was done with a manual kind of in situ EACH monitor that was brought in, measured, and brought out. For Head Start, we placed an embedded EACH monitor with the hope that that week-on-week score would help to see both continuous improvements and then provide that essential collaborative feedback. We're going to talk about that a little bit more, but I just wanted to make sure y'all got that point so that when we do, you understand. And then we also wanted to see, of course, similar to the Italy study, this is a very small study compared to that, but if we could see any relationship at all between these improved scores, maybe reduced detection of pathogens, and then improved outcomes for health and attendance. Remember, these kids really receive a lot of educational and learning services, as do some of their parents in those like mother-baby programs. I mentioned the previous pilot. As we can see, this is with the manual EACH monitor. We came into another school that was in San Francisco. Of note, this was a private school. You can see on the left, the initial measurement scores were B's and C's. This is actually above average for schools around the United States. I think the average score is something like 2.5. This was 2.5, 3, 3.6. After providing the school with this type of information, they actually did an HVAC upgrade. We'll talk about it a little bit more in the conclusion about how effective this was, but they were able to take their scores from C's and B's to A's and B's. Again, they started at an above average air exchange rate for the United States. Our air pathogen monitoring program, we were able to take 207 real readings over 2 months. We were intending to get more like 400 something. 61% of the intended measurements did not happen. This was partially due to some Wi-Fi and connectivity issues. We also found that there wasn't as much incentive possibly to really rely on this piece of equipment, that it required an extra step of sending cartridges to the lab, in part because they had the mitigation measure of antigen testing, which provided a very quick real-time feedback to what was going on in the classroom, and they were very familiar with these technologies already. So maybe air pathogen monitoring could be useful down the line when some other mitigation measures are not as available. But I also think that a key thing is we measured flu. We got some flu results. We told the directors this, but there was not a protocol in place on how to do with flu because we'd been focused on COVID for so long. So a key learning that we achieved was that if there's not a protocol in place for another virus that you may have identified, and we know schools were wrecked with RSV and flu this past respiratory season, then it's very difficult to provide that information without an action plan in place. So that's just a key learning that we didn't think about at first. With the EACH monitoring, the effective air exchange monitoring, we were able to capture 257 real data points over these 2 months in these 29 classrooms. Again, we were intending to capture a lot more data points, something like 300 or 400. Nearly 40% of these scores could not be reported, again, due to Wi-Fi and connectivity issues. This is with the embedded device. And so we'll talk about it a bit later, repeat it a little bit later, but it may be for some schools this embedded device is not appropriate just because the Wi-Fi doesn't always provide the connection. We couldn't find in the entire cohort, kind of looking at all the data, some consistent trends. So we went in a little bit deeper and looked at the details of specific classrooms to understand the narrative of what was happening and the specificity of ways that people responded to having these scores reported. And so really excited to dig deeper over the next month in some of the qualitative data we're going to continue to collect as we wrap up the program. I'll put some of the challenges in 2 big buckets that can be solved in different ways. One are operational challenges. Head Start does not own their own buildings. They have great facilities workers, but they cannot sometimes make some changes in their buildings that could have been useful for collecting some of the data that we needed and having that continuous reporting with the embedded EACH monitors. There was also kind of a widespread systems failure in February, which affected the number of data points that we could receive. This was not due to anyone's fault. There was also classroom-based challenges. There have been other mitigation measures that the staff there know and love. The antigen testing, we've all done a really good job with training people and helping them understand how that's a useful public health decision-making tool. And so there might need to be education and training, or there likely will be, on around the world on how air safety helps support those other tools, or might provide a wider protection. Additionally, with air purifiers, depending on the structure of the classroom, noise levels and competing daily priorities that teachers face, they're overworked, may keep some of those air purifiers from staying on, or they might not know exactly where to place them in a way that is conducive both to classroom learning and better air safety. We did capture a lot of rich qualitative insights. I briefly talked about them in the previous slide, but things that we really found mattered was that when a director and a teacher in a center had a very good relationship that had been ongoing, like providing mentorship and guidance, it seemed that the teacher and the classroom staff were much more open and able to have that sustained response to air safety. I mentioned operational infrastructure issues. There's also possibly, I'll show a case study where there's some buildings might not need to be upgraded. But I think really the richness that we got, we worked with an operations person at Primary.Health, who I absolutely love. Her name's Stacy. And some of these conversations about infrastructure and the educational needs led to a lot of improvements in how we were implementing the program and the type of training and contextual information we really needed to provide in this type of wraparound supportive way, so that the air safety program importance and the goals and the impact on the students and staff health were really implemented. And we're hoping, and we know that this will help to deploy other air safety programs as we continue to kind of pandemic-proof and support good public health in the classroom. Some of the case studies. So here we have a couple months of EACH scores. You see on the left that some of the initial measurements were 1 and less than 1 in some cases. We have a 1.9. So you see these scores were much lower than our initial pilot. So we're starting at a lower level, unfortunately. Center A was a center that was identifying as having a director who was really involved with the classrooms and the mentorship. But still, the first scores were taken without kind of this training and engagement that we have found that really matters. In February, we had the connectivity issues that we could not avoid. Of interest, on March 6th, there was a policy change that allowed asymptomatic children to return to the classroom, which added an extra urgency to the need for other mitigation measures. We feel that combined with increased training and engagement about the use of air safety in mitigating the effects of COVID and other respiratory pathogens really supported in getting some of the scores up in some of the classrooms. You see classroom 2 on the left, it started at 1.1, 1.9, and we were able to get it up to 4, 3.5, which was really a success case. We also have Center B. I'll very quickly go through this. This is an example, a center where we're not exactly sure what happened. It was considered a center where the director and the teachers really had some good relationships and mentorship, but the score started at 1 or non-existent. And really, we're not able to get them consistently up towards the end. So we're following up with more qualitative questioning and support to see what actually happened. And then Center C is one of these centers where these infrastructure issues became really apparent. We see, again, on the left, we started with scores that are pretty low, 1.7. And then we didn't get any other scores the rest of the study. Why? The outlet where the embedded monitor was plugged in, the embedded EACH monitor, meant that the refrigerator that was used in the staff break room would get turned off due to electricity issues. So choosing between lunch and air safety, lunch won.
They picked lunch.
Yeah. and I'll also just say a lot of these teachers are living in not in near poverty as well, like their salaries are not up. So bringing your lunch and having those resources at school are really important as well. Time for the discussion. So what we really found with all this whenever we provided information, we needed to make sure that empowerment was there so that people could plan actions and feel that they could act on the information they received. You can't give a classroom a low score and then say, what do? You have to say, this is your low score, this is how you can improvement, here's an air purifier to help you improvement, and this is how you sustain that over the course of a year. Really not giving those tools we feel can be harmful to buy-in, shared trust, and communication. And so really these empowerment programs need to begin before the actual information is received, or at least in parallel with it, so that you're always being in collaboration. Education really is key. I mean, these are schools, we know that. We know that from the past 3 years. The same way that we had to train people with rapid antigen testing, need to train them also with air safety. Additionally, there's multiple stakeholders in the school system that I'm sure you all know. There's the facilities people that are really important when you're doing kind of air safety programs. There's the teachers, there's the directors. There's the relationship with the greater community or even the policy makers as well. And each one of these people is important when you're doing the assessment, the management, and then the long-term planning that is necessary to sustain better air safety in the classrooms. The manual kind of in situ, place, mobile, effective air change measurements is very repeatable because you can go in, go out, you're not relying on that Wi-Fi, you're basically saying, here's your score, here's your action plan, we'll be back in a couple of months. And we have found, particularly in some of the lower resource schools, that having, again, the continuous with relying on the infrastructure may or may not be sustainable, but then coming in and out maybe, because then you're continuously in that conversation of like, here's your score, here's an action, let's come back and see it. Additionally, there probably needs to be some I think we'll talk about this later, but I'll mention it now, some local staff that are prioritizing air safety. Those are likely going to have to be external to the school, could be university students, could be a local community-based organization that does workforce training, but having people really, really focus where their number one priority is air safety and the facilities around that feels very important. And I'll have John talk briefly about the previous pilot.
Thanks.
I wasn't there, so.
Thanks, Mo.
Yeah.
One thing on your previous slide I'll add is that we are looking at how we might do an embedded sensor or a real-time sensor. So there's some technology opportunities for us to eliminate Wi-Fi, eliminate the need for power, and get that same data collected regularly in an embedded way. But we basically have dropped anything tied to Wi-Fi or IoT such that it can work in any school, anywhere. So there's a little more R&D on the tech side going on, and we can talk about that offline. One key piece of this is that we can measure if you do an HVAC upgrade. We showed that in our previous pilot. But what wasn't showed is the micro understanding of the impact of doors open and closed. There's been a lot of talk about safety of people locking doors of schoolrooms, but there's an impact of that. And so we actually did, because this is a lower cost assessment, we were able to quickly, at the same time as we measured doors open, look at the HVAC adjustments and doors closed. And what we found was shocking. In fact, in some rooms, the pathogen clearance rate was below the original measured state. And this was a great aha to say, okay, what more do we need to do, especially for certain rooms? You can see Sunroom and EastEnders, there were issues there. Since then, by the way, because we're able to make this additional adjustment, they've been able to fix those too. But this just shows how air safety isn't a one and done measurement, and purification isn't a one and done measurement. Some way to create a successful program over time makes the difference, and that's why we're here. And Mo, what do we get out of it?
I know I'm talking to other researchers, and I am one too. So I think one of the things, I love pilots, and I think there needs to continue to be an emphasis on linking these real-world pilots to metrics that matter for the policymakers and decision makers to make sure that that kind of research and impact is linking. These could be things like cost effectiveness studies. In schools, absences really matter, enrollment really matter. So it's a relationship to improved air safety and those particular metrics that can lead to more interest and buy-in from really the decision makers. I also, I'll geek out for a minute. I think we focus a lot on COVID-19. We know schools were wrecked by RSV. There could be improved air safety helps with multiple pathogens, not just COVID. I'll do a quick shout out also to tuberculosis, which we don't focus as much in the United States, but globally there's other airborne pathogens that really could be focused on. The long and short-term impacts, not just health impacts due to absences and illnesses, there's mental health, cognition that could have compounded real-world effects over years. And then, of course, building scenario projections and models that really help us understand these and feeding those to decision makers and other community members. We're almost done, I promise. And this counter here is here. For Head Start Oakland, we've been, of course, sharing in real time learning opportunities to figure out how to support and better their program alongside the research. These robust empowerment programs really need to be rolled out alongside the air safety technologies, and developing a practical operational plan for any type of information that is shared. What is the plan to implement afterwards? What's the plan, understanding, and opportunity? This external staff, again, could be graduate students, could be university students, could be a CBO with workforce developers, figuring out who those are in the community and bringing them in to really support the air safety program. Also, City of Oakland has policy priorities, which include improving indoor air quality just because of those outdoor air quality issues. And so combining kind of objectives with that larger policy goal has been we feel like will be really important. And then, of course, repeat funding. And last.
Yes, and almost in time. Woohoo! So this had implications for us as a company as well and our offering. Obviously, we've harvested the technology and operational insights to prepare a program, and really our focus is on fall 2023 and making sure that we're fully ready for it. What's going to be giving us a bit of a tailwind, frankly, is the fact that there's a new standard. So there are building codes for how the ventilation in this room are set up. For every building in the country, whether it be a schoolroom or hospital, there are standards for airflow. There's actually a new standard following the health emergency that's going to be announced within a month or two, which is going to look at how ventilation affects infection risk. And so we're going to be rolling out this program with that as a bit of a tailwind to make sure we're ready for fall 2023 and beyond. As part of that, we're going to be creating evergreen content, so webinars, training materials, marketing support, and looking for collaborative partners on that. We're going to be working with state health orgs and especially school districts. And we're going to be leveraging our experience in program management, which was done. Obviously, our work in schools in California is winding down, so we have a team that I think is really ready to take this on and work on some of the reporting and analytics and training. So we have a whole program that's coming to market based on this, and we're looking for partners, which is why we're here. And I'm so excited to hear about the purification program to see if we can make a difference and help out here. So with that, I will say, first of all, that our team, Mo has done an amazing job. Thank you, Mo.
Thank you. I'll just say, as a researcher, it's super fun to work with an operational team, and I think this group is all about collaborations, and it's great.
Yeah. And then to recognize that we had a significant operational team in Oakland and across the country, really, that supported us in putting this together. And thank you all here for hosting us. It's been a great event, and we've really enjoyed it, had fun. So thank you.
And we have emails if there's no time for questions.
Oh, right, questions, yes.
That's what I thought. Yeah, sorry.
So we're going to move on to the next presentation, but I know you guys will be around, so if people have questions, they can go ahead and reach out to you. But
yeah, thank you.
Please do. Thank you.